first of all thank Jyoti Dev and the Keshav Trust for inviting me to chair this session. Type 1 diabetes management is always very tricky and difficult, and I think our goals are never met. As per the recent ICMR registry, I think the A1C levels usually is around 11 or 12 in Indian patients. Even in US, the A1C level, according to the new study came last year, A1C level in US in type 1 diabetes was around 8.4. So it's a very difficult thing. Failure of management in type 1 diabetes is very common. So today we have a topic on that, and the speaker is Dr. Rishi Shukla. He's a head of the Department of Endocrinology at Regency Hospital, Kanpur. He's very well known in the field of type 1 diabetes. He organized for the first time in the country a national type 1 diabetes meet. He has several international and national presentations and publications. And I think he should give us some light on how to manage type 1 diabetes in a scientific and very useful way. Over to Dr. Rishi Shukla.
Good morning, friends. Thank you, Dr. Arun, for good words. And at the outset, thank you, Dr. Jyoti and Sunita, for the opportunity. And it's always been love to be here and love to be this part of country. The topic actually allocated to me is pretty tough because the reasons are uncountable. And if you say it, 3-4 hours talk. So medical reasons, psychological reasons, so many things are there. So I tried to compile everything in 15-20 minutes. Let's see if I can justify. I would touch the things, and rest of the things I'll be leaving upon you for the discussion. I think that would make things more interesting. This was one meeting that I did just last year in RSSDI Lucknow. In association with RSSDI, we had a patient education program exclusively for type 1, and certain stalwarts of country helped our type 1 diabetic patients. He's Dr. Lawrence. He is a BD Global Chief. He himself is a diabetic for last 50 years. So he was a role model. Dr. Vijay Lakshmi Bhatia from SGPGI, Dr. Ish Bhatia, Sunil Gupta from Nagpur, Deepak Dalal Mumbai, Archana Sarda, and so many others. And these are all beautiful type 1 children. And I also asked Dr. Jyoti to be part of it, but because of his busy schedule, he could not attend the meeting. What am I going to discuss? What is the burden? Identifying missing links to a successful type 1 diabetes management, and exploring the reasons, and finally the summary. Type 1 diabetes is incurable, lifelong condition. There are so many conditions which are incurable and lifelong. But the only difference is it starts very early in the life. If type 2 diabetes or hypertension or coronary artery disease or asthma, it happens at the age of 40 or 45, it's all right. But here it develops in age of 5, 10, 15. So this is the major difference. They have to live whole life with this. Insulin requirement, glucose profiles may vary on day-to-day basis. All of us have undergone our adolescent and young days, and just go back and try to understand how your mind flickers on those days. Therapy must be reviewed and adjusted frequently to achieve long-term glucose control. So these are the challenges. The Indian data as such is how many type 1 diabetics do we have in India? This is the idea of data, so we cannot debate much. As such, we have 70,000, but I believe the numbers are really much more. This is the same thing which Dr. Arun was mentioning. This is a very famous diabetes control and complication trial. In fact, one word about this trial. It came in 1993, if I recall precisely. And this was first trial to show whole diabetic population, which includes type 2 also, to show the path that if we control our blood sugars very nicely, not only we can control complication, but we can also revert it. And eventually this was proved in with UKPDS in type 2 diabetes. So look at this. Even in DCCT intensive treatment did not achieve target less than 6.5. Only 44% of patients reached less than 6.5 at more than one time. So grossly the control is bad. What are the missing links? Basically, I have divided into three categories: the medical, the psychological, and the social. The medical part is one, if you go to the treatment, using of mixtures. I'm just touching these issues as I have briefed you, and then we can discuss. A very humble advice to all physicians treating type 1 diabetes: please do not write mixtures, the mixed start or 30-70. They are not meant for type 1 diabetes. We need to write multi-dose MDIs. 1 long acting, 3 short acting, 2 long acting, 3 or 4 short acting. So we have to tailor the needs. So this is a very humble suggestion and request. There is always a mismatch between food and insulin. It happens. Like Gopika in early just called me, sir, I have a UTOC, and it just skipped my mind and I skipped my breakfast. Had I been a type 1 diabetic? So this happens very frequently in day-to-day life of everyone. So type 1 diabetic has to be briefed, has to be empowered that you have to manage your blood sugars and insulins accordingly. Insulin storage issues are also there, because in rural part of our country where temperature is more than 30, 35, 40, the storage facilities are not very good. And even in certain parts of our country, electricities are not there. So the storage problems are also there. The diet issues. Diet is actually a very challenging thing. If somebody asks, if I ask you a question, what is the most important thing in our life? I think I'll say one line, and that is diet. Because food or roaming around or sex, these all things come later, or a career. The diet is most important thing. All of us like good food, all of us enjoy good food. So how can they be kept away? And we are always sympathetic about children. We say, let a child have this food. We give them chocolates, we give them chips, to our children in our home. How can type 1 diabetic be kept away from this? This is a challenge that comes. So what is required is, we need to brief them couple of sessions, and my understanding is, I have been dealing with these children and type 1 diabetics for more than 2 decades. Children understand better than adults. If you say them, Sam, you don't eat, it is not good for you. Okay, sir, I'll not eat. But you have to follow same practice in the home. The monitoring is another issue. After a couple of days of monitoring, the people become lazy. The parents, the children, the adults, everybody. Why should they do monitoring more frequently? Again, they are not either empowered, or they don't do the dose titration. For every ups and down of blood sugar, they cannot go to their diabetologist. So what is required is, they should be empowered that if doses are this, then you have to handle your blood sugars accordingly. If the blood sugars are this, then you have to handle. The hypoglycemia is another challenging issue. If I call it like this, if you are moving on road, you will have accident. What you can do, you can reduce accidents. So the frequency and intensity of hypoglycemia, we can always reduce. Lipohypertrophy is another area. We seldom put our hands on our patient's body. Possibly you're not going to live a nice life. You are going to die early. So many things come. Relationships. It includes marriage and the affairs. So again, I have n number of stories where a boy liked a girl. It is a beautiful love story. They moved around, and later when boy came to know the girl has diabetes, he moved away. And look how painful this is. And look from the girl's perspective, look from the parents' perspective. So it is very tough. The market of marriage is unfortunately very calculative. It moves more with mind, less with heart. So this is another issue that we handle in day-to-day practice. What is society's outlook? We'll share. While traveling, these children, they have to carry their needle and insulin. So insecurities is another issue. Poverty is another issue. Sometimes the children the parents don't have enough resources, and sometimes they feel it is better that child dies. I have seen those situations and circumstances. So we are supporting, but still how much one can support. So empowerment, you make them understand. But on the other hand, the double diabetes, they eat a lot of food, gain a lot of weight, and the insulin resistance is also a known thing. Coming to the medical issues, this is a very busy slide, but I'll just touch one by one. These children at times avoid doses in real life. At times it is because of pain, but majority of them are not because of pain. It is basically because of attention-seeking behavior. They want to admit in hospital, they want to admit in ICU, and they are getting attention by the family, by the hospital, by the friends. Insulin devices, the site of injection I have discussed. The lipohypertrophies I have discussed. The insulin autoantibodies are less a common thing. Then timing of insulin, the mismatch between food and insulin, that has to be kept in mind. So this is another issue. These children, because of erratic blood sugar, the gastrokinetic disorders are quite frequent. So belching and constipation, autonomic gastropathy, Down and Somogyi phenomenon. Children have brittle diabetes. The Moric syndrome is uncontrolled diabetes, leads to short stature, hepatomegaly, poor development of secondary sexual features. One thing that we usually miss is the celiac disease in type 1 diabetes. Please, if you have a younger diabetes, ask for 2 tests. One is a thyroid, a very simple test. Another is a celiac disease, tissue transglutaminase test, TTG. Because this is around 5 to 7% of type 1 diabetic population, and once you detect, the treatment is very simple. You restrict wheat. The gluten-free diet is required. And it is very commonly associated. They have other endocrine disorders. They have to undergo puberty, pregnancy, infections. So many other things are there. I'll touch one issue, and this is the hypoglycemia, because this is again a very common problem with these children. As A1C goes down, the complications also go down, but at the same time the hypoglycemia increases. Look what happens to the hypoglycemia in clinical practice. Do patients inform their doctor of a hypoglycemic event? Majority of them don't. Does the doctor ask about hypoglycemia during routine appointments? This is the Western data, 83%, but I believe not more than 50% people ask about hypoglycemia. Patients themselves tell about hypoglycemia. So please inquire about hypoglycemia. Every children will have hypoglycemia. Ask about intensity and the frequency. And if you go for CGMS, many of them have hypoglycememia, because now we are doing CGMS very frequently, continuous glucose monitoring, and see that it is a very common thing. And just by a lifestyle, diet, activity, sleeping patterns, the glycemia of food, you can do a lot with these children. The severe hypoglycemia is much more frequent in type 2 diabetes than type 2. This is the dark blue is type 2, and this is type 1. So in any case, type 1 hypoglycemia is much more common. A word known as hypoglycemic unawareness. This is again a much more frequent in type 1 diabetes. A number of my type 1, I'm seeing type 1 diabetes for more than 50 years. They say, sir, I have hypoglycemia and I do everything. And at times even I fail to know. So hypoglycemia is very common. We have to empower them, and that is the theme. Coming to the psychological issues, they have fear of hypoglycemia, they have fear of long-term complications. So all this leads to anxiety, and they also have type 1 diabetes related emotional and physical burden, interpersonal and social distress, the treatment related issues, the lack of support. So all is sufficient to give the treatment, the psychology. I discussed so many issues, sufficient to give the psychological stress. What are the social issues? Coming to the school. Schools are usually not ready to take responsibility. Non-cooperation of teachers. They say, we have so many children, I can't take individual kid, and every kid has some problem. So because of this reason, children have absent school days, not permitting they don't permit. At times school authorities don't permit them for games, because saying if something happens, who will be responsible? The meal adjustment, and we underwent into this. We had a lot of work upon this, and what I did, the school management teachers are not aware of the problem. Once we prime them, once we brief them, possibly we can do a lot. We had a paper in International Society of Pediatric and Adolescent Diabetes 10 years back. The behavior problem in type 1 diabetes in India. And we concluded that most of the people express pity after knowing the diabetes in early, say, oh, you developed diabetes so early. Majority of type 1 diabetes are not comfortable in social gathering because people poke. If everybody pokes you, how is your heart? Are you normal? If 10 people ask you, I think you'll not be very comfortable. So that makes them more irritable. And the conclusion came that relatives who know about their diabetes, they hurt most to their type 1 diabetic children. And significant number of type 1 diabetics feel that they should not make their diabetes public. So we always tell them, should I reveal diabetes or not? Ideally, you should reveal. You should be honest to yourself and the society and people. But I came out with a blanket statement, reveal them to people with whom you are comfortable, with whom you feel you can help. They can help you. So it should be like this. Society feels a minister, I remember, a cabinet minister asked me, are they normal? Do they have normal expectancy? So this is the problem. And some people ask me, can they live without injection? This is actually a first national type 1 diabetes meet I did, first in India. Instead of doctors, I asked patients from all across the country to come. We have 1.5 day meeting with patients of type 1 diabetes. And this is what I discussed about marriage, to alleviate the problem of marriage in people with type 1 diabetes in India. This is a very beautiful couple, both are chartered accountant somewhere from west of our country. And again on this we had a paper in SPAD. And what we concluded that maximum problems are with females due to social circumstances. It is tough to get match for both the genders in market of arranged marriage. Again, love marriage is again a problem. Love should be not true but very true. Then only the guys accept. Awareness of type 1 diabetes and their problem is very less in society. Therefore, nobody wants to marry a sick lady. They call them a sick lady. So that's the problem.
Dr. Shukla, time is up.
I'll finish in 2 minutes.
1 minute.
1 minute? Okay. Done. Poverty is again an issue. So we have the television watching is another issue that is associated with uncontrolled HbA1c. The most important thing is now what to do with all this. I believe the most important thing is physicians and the patient's rapport. Once this rapport is made, possibly we have done many things. And to sum up, type 1 diabetes is a disorder that implies relentlessly and often unpredictably on parents' lives every hour and every day. Living and coping with type 1 diabetes requires patience, lifelong commitment, and personal responsibility for health. Not only patient liability, but it is doctor's responsibility too. Patient education and empowerment, along with good physician-patient communication, is key. So that is one thing. And finally, the point that came in my mind is physicians need to understand type 1 diabetes with a very humble comment. They don't understand. They don't want to give enough time because type 1 needs more time. They don't give more time, and all of us are busy. So please give 1 or 2 minutes extra. You will be able to save a lot of morbidity and life in these patients. And what I request, expect and anticipate is involvement, compassion and empowerment are key. This is physicians' empowerment, not the patients, are good outcome. This is again one of the meeting, and all patients with candles. So greetings from Society from Prevention and Awareness of Diabetes. This organization is helping type 1 diabetes for more than 2 decades. And with this, thanks a lot for your kind attention.
Thank you, Dr. Shukla, for a very passionate and informative lecture. Topic is open for discussion.
There are no questions. What percentage of our type 1 diabetics progress to nephropathy? Because I have seen this abroad, but not in our country coming for a transplant or except 1 or 2 patients. What percentage of them proceed to nephropathy within a short period of time? Type 1 diabetics in India.
What percentage of the type 1 diabetics
go to nephropathy, and what is the time span they go to nephropathy after your diagnosis?
Actually, if children are prepubertal, the first 5 years we consider as safe, so we don't see it very frequently. So this is one thing. Once children enter into puberty, the microvascular complications, which includes retinopathy and nephropathy, are seen very frequently if HbA1c is on the higher side. And in my experience, giving the HbA1c, I see in around 20 to 30%, more than 15 years of diabetes, 15, and it is in fact more than type 2 diabetes, because the sole reason is type 1 diabetics live longer than type 2. I mean, they start their diabetes at the age of 10 versus 40. So by the time they are 40, 45, more than 40, 50% of them have complications. And not only micro, they are equally prone even in early 30s or 40s, because more than 15 years of diabetes for macrovascular complications. The coronary artery disease, I believe, is more common because we don't talk it so much because we don't see them because of less percent. So it is very common.
What is the A1C goal?
What is the A1C goal for the type 1 patients according to age-wise?
All right. Actually, earlier SPAD only came out that children below 6 years, 6.5 to 7.5 if I remember correctly, we need to be flexible. But once age advances, maybe 8 or 9 years, it should be somewhere around 6.5 if you can, 6.5 and 7 if you can maintain. So flexibility is for younger children only. Otherwise, the goals are same as for adults. Because see, complications don't look at age. The complications look at blood sugars. If there is a lot of glycemic variability or uncontrolled diabetes, the complications are going to occur. So the goals are more or less same, except for the fact that we kept flexibility for younger children. 3 years old diabetes, how will you manage? Here we have to have flexibility. 5 years, ask him to eat, he'll not eat or she'll not eat. It's up to her. So here we have to have flexibility.
I think we will close the session now. Thank you, Dr. Shukla.
Thank
Please
you.
give him a big hand.